Happy holidays, everybody. I think they should get like an extra CE credit for getting on here with so many other things going on during the holidays right now. All the gifts for the teachers and the vendors in our practices and your employees and your associates and all that. And just if you've carved out an hour and a half to spend with me and Josh and Jordan, I think you should send these people an extra hour of CE. Talk to Brooke about that, please. All right, so tonight, for those of you who have not done a Mash-Up with us yet, a Mash-Up is taking what we call the baby course of SOAN and SleeperOne⑤, like teaching you the basic stuff and mashing it up with a second portion, which is some more advanced things. So tonight we're hopeful that by mashing this together that you come away with some nuggets that maybe it's things you've heard before, but repetition is the second law of learning, or maybe it's something new for you tonight. So please don't tune us out if you're like, I know all this. I promise, stick around for 2 more slides and there'll probably be something new and juicy for us to share with you. So again, this is going to be the Mash-Up course tonight starring Ann and Josh. And this is me.
Did we want to do, sorry, real quick. Did we want to do questions only at the end? Or do you want me to, how about I monitor it? If there's something that's apropos at the time, I can bring it up if you want, or we can do them at the end, whatever you think.
It doesn't matter to me. I think Jordan likes doing them at the end. So if people watch the webinars again, all the questions are captured at the end.
Yeah, exactly.
But if there's something that we're like right in the weeds on something, please, and someone asks something like right at that moment that fits, yes, please, like, let's get it answered right then and there, if it applies. So I went to this full trashy school called Florida State University. Then I went to Iowa, and then I did my training in San Antonio, and I built a practice almost 30 years ago now from scratch. And probably the number one thing that gives me the credibility to do this webinar tonight is all the mistakes I've made. And my goal is always to move the needle quicker for everybody else. This is not a mistake. This is my husband, Matt. I met him the first day of dental school. He's a general dentist, and we practice and live together. And these are our 3 boys, Matthew, Luke, and John. They each have a lovely woman by their side. I will shortly be able to tell you that these are their brides. They're both getting married the beginning of next year. And then this is John with his girlfriend, Sal. So we are all the people on this screen. We're going to Mexico the week between Christmas and New Year. So that's what, instead of things under the tree, we're going to be on an airplane together having a great time.
This is like when you go to the store and buy a picture frame and all like the pre-done pictures of everybody, like the good-looking families in there. That's your family, Dr.
I got some good-looking. They're good-looking, and they're really good human beings more than anything. Here's another great human being. This is Megan Sharowski. She's my business partner, and she's also a KOL for NuSmile, and she is the, the yin to my yang. We make the world go round at our practice, and I love being with her. And then you can't make anything work without your team. We have a fun-loving, crazy team. We're up to 34 people now. We just had our Christmas party last week, and it was insane. Thank God it was a 3-ticket drink limit, because I don't know what would have happened if there were 4 tickets. Also run the Tot Spot, which is a tongue tie and airway center. It's inside of my dental practice. And if any of you have questions on any of this, please reach out to me. Tackling these two, or juggling these two, I should say, running a practice and running an airway center is challenging, but I do feel like I have a lot of it figured out at this point because I've been doing it for almost 15 years that way. And it's Holly Tree Pediatric Dentistry, Matt is Bynum Aesthetic, and then we have the airway center. This is what the building used to look like. We just gave it a facelift, and we also increased the square footage from 6,500 to 10,500. And we had the pleasure of having Dr. Josh come out and teach his course, which he's going to talk about right now.
Hey, everybody. Thanks for everyone for being here tonight. As Ann said, this is a tough time of year, and everybody, I'm sure, had long days and your schedule is packed. So our job is to pack this with as much information as possible. Just a little bit about me. I'm a 2nd-generation pediatric dentist, and I've been in practice over 20 years. So I spend probably about 70% of my time-ish seeing patients, and the other 50% of my time teaching. So I do a lot of these webinars. Both Dr. Bynums are kind enough to let me come out to use their facility. And so my hands-on teaching center is based in California, and we've spread out to 4 different sites statewide, and 2 of them this year will be at the Bynum's office. So I'm excited about that. I really focus a lot of my teaching on hands-on clinical dentistry, so anterior, posterior, direct composite. But I'll talk to you about zirconia if you're having issues with that, with NuSmile. I love talking about that, especially speeding up your prep designs. I moved into my new facility about 2 years ago now. So I moved into 6,000 square feet, and my training center is all integrated into the office. And besides, thank you. Oh, that's right. Hitting buttons. Dr. Ann gets to go forward for me. Thank you. Just one of my operatories, yes, you can use microscopes for peds. We do that a lot. I believe in using magnification. And when we're not seeing patients, we convert the office into the training center there. So just some photos of what things look like under the scope and clinically. And I'm super excited. So both Dr. Bynum's and Dr. Megan were kind enough to let me invade this year. And we had this was by far the most fun course I've ever taught because I had fun people. And this year we're doing 2 more on the East Coast. One is going to be a brand new course that for the first time combining orthodontists and pediatric dentists talking about treatment planning and all that good stuff. So if it's something you're interested in, please come see us. And that's my contact information. I am super reachable, as is Dr. Ann. If you have questions about all the things we're going to talk about tonight, you have questions about restorative dentistry, you have practice management questions, NuSmile makes it I think almost a requirement now to have a deep bench of KOLs. So we will help you with this kind of stuff with Intraosseous or other things, anything pediatric related. My email address is there and my phone number, and I'm on Facebook quite a bit. So please feel free to reach out to me.
All right, we're going to start tonight by taking a poll. We kind of want to read the room, see who our audience is. Jordan, can you help us with that? So if everyone will just kindly answer these questions for us, and then Jordan will let us know, give us kind of a read of the room.
Yeah, it should be up now.
But there ain't nobody taking it.
Pam Butler's out there. She'll take it. Hi, Pam.
Oh, there we go. First, I thought there were no people on the webinar. I was like, well, I'm going to bed early tonight. All right, about half of you have answered. We're going to sit here till more of you do.
Yeah, we'll just stare at you.
We'll give this like another 10 seconds or so. Let everybody enter. But right now it looks like how often you want to see a Mastering Intraosseous webinar. About once a quarter seems to be the majority. There's a couple asking for once a month and once every other month. Which device do you own? We have no SleeperOne users in here that have answered, at least. Pretty much split between SOAN or not owning one. Who use them exclusively? A couple of you on everybody. A few of you on patients until a certain age. A few of you will use it and then occasionally fall back on traditional syringe. And then, those who don't own it yet. Delivery method preference. So only a few say cruise, none say drive. Pretty much no one knows. So we'll jump into that.
Well, and one thing I want to say on here too is there was over almost 60% of the people on the webinar tonight don't have a unit yet. So, Christmas is coming. I mean, 100% depreciation, bonus depreciation. You may want to be thinking about getting one of these and make it your New Year's resolution almost to, I would recommend that you do this. And I'm not just saying that because I'm on here. I think this is well, I know this and adding 6 more chairs to our dental practice are the 2 things that have changed the trajectory in our practice in the last 2 years. Okay, we're moving right along. All right, so we're doing a mashup tonight. Going to talk about some beginner stuff and some more advanced things. And then the other thing is Josh and I are going to mix in a few pearls here, the practice management pearls, so that you can have a few nuggets to take back to your practice tomorrow or Monday or next year, whenever you go back to work. I don't know. The holidays are weird.
So I'm showing my age a little bit, and I started using NuSmile products back in my residency in 2003. So I've got to see the progression of all of the inventions and things NuSmile's brought to market. I use pretty much do everything on here. So NuSmile, besides bringing you supplies and things, the big thing is to support education and all this. So if you have questions in regards to any of these products, I like to pat myself on the back that I know all these like the back of my hand. More and more, I've been doing more zirconia permanent crowns. I got to go to Mexico this year, Mexico City, and give a lecture on it and really increase my knowledge and my speed in permanent zirconia. So if you have questions, BioFlex or any of these things, BioSem, besides what's on here tonight, please reach out to me and I will be happy to help you personally or, your associates, your team.
I think one thing that I have stared at this slide for 2 years now, giving these webinars, and it has just come into my frame of mind that if you take a Restore course, you literally use every single product.
That's the point.
That is on this slide. I guess I never really put together that you're actually getting your hands on all of this. Okay.
Yeah, it's basically a 1-day pediatric dental residency, right?
Yeah. I don't know, that went by me somehow. So what is intraosseous anesthesia? If you look at that, that's 2 long words, a lot of syllables, definitely a lot of vowels floating around up there. I must have fallen asleep. I mean, I think we had anesthesia lectures and practiced on each other for maybe 2 days in dental school. I don't know what that looks like now, but it was intraosseous anesthesia was like not part of what we learned. It was how to do the block. And I had to really understand and think back to myself, what do these words mean? And this is what it means: into bone inject. That's all. That's the difference of this type of injection, is we are going into the bone. So just don't overthink it. I think that's one of the things that does get people in trouble. They have fear of these devices, or, it's something new. If you could do this as a dental student and you were giving infiltrations, palantines, mentals, linguals, if you were doing all of that as a dental student, as a seasoned pediatric dentist now, this should not terrify you. This is just another great tool in your toolbox.
That's me. So one quick story that's not on here. Actually, one of my many mentors, who's a retired prosthodontist, he asked me to repair one of his teeth last week. And he actually was one of the co-inventors of the X-Tip. And I got to use the Quick Sleeper, we're not talking about that device tonight, on him. And it was really like, it was a pretty cool moment to have somebody that, was part of bringing a device that was manual, and he was amazed. And he said it was the easiest dental appointment he's ever been through, because he has a hard time getting blocks. So the thing to understand is, when we bring technology in our office, for a GP, sometimes it's cool, right? They have a new laser, they have a new, whatever scanner. A lot of times in peds, parents don't like new things because they don't want you experimenting on their children. And sometimes a new device may feel foreign to them, or they may give you that look like, should you really be using this? The term intraosseous, or the technique of intraosseous anesthesia, this is definitely not new. Okay. And so if we just, we look at, back in the literature, and this was, a few hundred years ago, the lateral spread of the mesh of cancellous tissue as easily as in a real cavity. Analgesia is immediate and absolute. So back, in this piece of French literature, French, medical documents, they were using intraosseous anesthesia way, way back then. And what they found is that if you deliver your local anesthetic into that cancellous tissue, everything around that cancellous tissue will automatically become numb. And I think the key component there is absolute, and it truly is absolute. If you give in the right position and the right amount, you will have profound pulpal and odontogenic and soft tissue anesthesia. Yep. So 1906, that was a while ago. So many of us have had huge changes in technology in our practices. And if you look at that dental syringe, things really haven't changed since then, right? We have digital x-ray, we have scanners, we have all these, amazing pieces of technology, but we had a syringe. The only difference of the ones from the 1900s is that the needles were not they weren't disposable, and you had to sharpen them yourself. But I will tell you that there has not been a piece of technology, maybe secondary to digital x-ray, that has made such a dramatic change in my practice. And I know Dr. Bynum's the same way. As I have only picked up a standard syringe maybe 3 or 4 times in the last, I don't know, more than a year and a half or more in my practice. And that's just when one of my associates stole my SOAN from me. So I could not even wrap my head around giving a block to a 5-year-old these days. I just couldn't even think about it. So SOAN and SleeperOne, we mentioned both devices. What do they look like? They both do the same thing. They both will deliver intraosseous anesthesia locally. The way I describe them to parents is these are digital pumps. So if you look at the business end, the needle on both of these, it uses the same Effitech needle. And to make it very simple, one is wired, one is wireless. I personally, my preference is the SleeperOne. I just like the way it fits in my hand. I like that I can see the lights all the way around it. It is less expensive. I have it wired into my operatory. Once you get into this, I promise you're not going to just want to have one. So I know some people like to have one SleeperOne in their main op and then SOANs in the others. Really, they're both going to do the same job. Just one is wired and one is wireless. And it's a little bit of cost difference. Yes, there's some setting differences, but really, all in all, it's a matter of wired versus wireless, and that's all. So what benefits? I think that's you, Dr. Ann.
Yeah. So what benefits are these going to provide to the patient, right? It can't just be all about us and what we're getting out of the deal, but most importantly, the primary thing is what are we providing to our patients? And there was a study done in May of 2025, just this year, and it was done with almost 80 patients in this age group, and they did a block and infiltration, and they used a SleeperOne. These were the 3 different things that they did, which SleeperOne, they give an intraosseous injection. They looked at needle insertion, anesthetic delivery. They asked questions about these things, the treatment and the post-op. And at the end of the study, it was shown that children in the SleeperOne group had significantly lower pain scores during the needle insertion, anesthetic delivery, and treatment. And the post-op discomfort decreased significantly, especially at the injection site. So, that's one thing. These devices have been around in other countries for quite a few years, and it's just taken NuSmile to have our back and get this FDA approved, because the United States, we're sticklers about stuff, right? We're like, everyone's lawyered up and suing for this and suing for that, and the FDA is there to protect us. And protect products from getting on the market that shouldn't be. And so NuSmile is the one that went to bat for this to get it on the market so that we can be using this. And so this is a study that was done. It is done in the International Journal of Pediatric Dentistry, but it is a very current study, and it was done very well. I have the QR code down here if you're just, bored and have nothing else to do in December and you want to, draw a bath and pour some wine and read that journal article right there. So, again, just great information that we're being compassionate to our patients. Big one right here, no collateral numbness. So no more chewed up lips, no more trips to the emergency room for an ER doc to tell you some nonsense about allergies to anesthetics. Everyone can go to Chick-fil-A or McDonald's afterwards and get a milkshake and a burger or chicken sandwich, whatever they want to get. And no one's leaving your office with a gauze hanging out of their mouth and spitting it in your bushes on the way out.
Dr. Ian, how many patients have left your quite large practice with a numb lip since you've been using these?
I mean, none.
Zero. And I am the same way. That's a big deal. That's a big deal.
Especially if you think about a special needs kid who can automatically start chewing or scratching at it. And I mean, they're in more jeopardy of harm when they leave your office numb than when you're actually doing the treatment. Because once they get out of your chair, then they're like, what is this? I don't have control.
Yeah. And one thing that I noticed was once I stopped having numb lips and tongues, I realized the amount of our patients that, they would get through the injection, but they would start fussing a few minutes later. And I never realized how much of that was because they didn't like the feeling of their lip and tongue. So, behavior wise in my office, I'm actually going to have to give up my conscious sedation license because I just don't need it anymore, which is unbelievable to me.
You want to talk about this at all? These
Oh, sure. So, you should not, that was kind of my intro. So you should not, if you follow all the rules, should not have a numb lip or tongue. The only time that I've had anyone even mention this is they were new to these devices, and during the first stage, and we'll talk about that, they just delivered too much. And instead of being in bone, they were actually in the vestibule. But I can confidently tell you that, and you can call my practice and ask any of my team, I have not had a numb lip or tongue in my practice since I've been delivering all local anesthetic intraosseously. And it is very nice as a practice builder when you tell parents, hey, nope, you can go ahead and take your kids to lunch. That's a big, see their eyes light up, right? Because often, especially our op patients in the morning, parents are pulling those kids out of school. So we can just send them back, or they can go to lunch with their parents and not have to worry about numb lips or tongue. So we just don't have that issue anymore.
So the benefits to us, right, is that providing, as a specialist taking care of the patient, it numbs the patient immediately. So now you have the option, if you're backed up in the bay and you've got 4 or 5 recalls to check or a new patient or whatever, fine, get up, numb the patient, get up, go check the bay, clear the bay, come back and do the op. But if you're not in that scenario, if you're like, oh, I've got time to get this done, it's a little occlusal on T, or I just got to pop out, 2 teeth for C&H for an orthodontist or something like that, stay in the room, get it done. It gives you a lot more options. One of the biggest things that we've seen from a production and a financial standpoint is most of our days are 2 or 3 doctor days, and we each see 10 ops between 8:30 and 1 every day. We book every 30 minutes, and we're able to clear a room in 10 minutes and work in. Each of us probably works in at least 2 more ops a day because we know we're not eating up that time waiting on the anesthetic to bake in the patient.
So what are some other benefits of intraosseous anesthesia? So the term pain-free, I'm always careful with that because I never want to guarantee someone that our parent or patient that they're not going to have any pain. But I can confidently tell you that today, if I have 1 out of maybe 15 kids, if that, actually even feel the first stage of the injection, I'm very surprised. And so we have to be careful, with the terms, but I can confidently tell parents they're going to have little to no pain with these injections. I wasn't able to do that before. One of the things we need to understand is that, of course, in the soft tissue and in the into the osseous plate, that's highly innervated. But once you get into the cancellous bone, there's no nerve endings there. There are nociceptors. So your patients may feel pressure. So once in a while you hear a grunt, and what they're feeling is just pressure. And I make sure that, the parent understands that. If you give the correct volume in the correct area, you do not need to worry about a supplemental lingual palatal injection, which is a big deal. One of the most important, my kind of seminal events where I thought I'm never giving normal local is I had pretty early on, I had a general dentist send me a 10-year-old with number 3, and it was hot. They could not get that patient numb. I gave them 1 IO injection, and I think I went a little heavy. I gave about 3/4 of a carp of septo, and that patient was profoundly numb. lingual, palatal, buccal. I mean, and I just took out the tooth and that was it. So not having to give supplemental injections is a big deal. It really is a big deal. We can just keep on clicking through these. No collateral numbness. Bilateral mandibular treatments happened today. So we had a patient scheduled for 2 different appointments because 3 and 14, 1930, all their 6s were very large caries. I didn't know if the patient was going to be his first time doing restorative on them. I didn't know if the patient was going to be cooperative enough. We booked enough time to do things, but I did have. And then, patient was, mature enough where you'd ask parent and patient, hey, are you okay to get everything done? Rock and roll, and we did the other side. This whole idea of having a midline and worrying about that is gone because you're numbing just next to the tooth. You're not worried about the IA anymore. So we will continuously add, and just like Dr. Ann said, we will add additional teeth on all the time. If we've scheduled the time, I don't have to worry about where in the mouth it is. I don't have to worry about bilateral blocks. I've been able to then decrease the amount of appointment times for many children. And that's a big deal. I mean, you think about your overhead. If you want to have a little bit of a sobering metric in your office, take your overhead for the entire year and divide that by how many hours you worked total during the year to get your overall cost per hour of running your practice. And then trust me, you will definitely push your teams to want to be able, when appropriate, to minimize the amount of appointments because it's costing you time every time. It's better for the patient, better for the doctor. When we say immediate action, that, just a quick clarification there, that is odontogenic. Okay, so that is the tooth. If you're, again, putting the right amount of local in the correct area, odontogenically, you will have an immediate effect of profound local anesthesia to that tooth. Some people have mentioned in the past, I tried to go into the palatal gingiva right away and the patient was feeling it. We need to remember that we are now giving the local anesthetic from the inside out and not the outside in. So there are some times where I wait a little bit if I'm worried about soft tissue, or I may need to, give a little higher amount to make sure I get blanching on the contralateral side. But teeth-wise, it definitely is immediate action. And if you give enough local, you will have profound soft tissue and hard tissue anesthetic. And you can just go, like Dr. Ann said, I have the ability now. Now, one piece of advice is don't necessarily tell the parents immediately if you don't think you're going to stay in the room that it's immediate, because if you need to get up, sorry, this dog's barking in the background. If you need to get up and do some checks, you don't want to tell me it's immediate. We can start right away and then you'll leave for 10 minutes. So it's a little bit of smoke and mirrors where I just, I might mention, well, they're going to be numb quickly, but just, a quick heads up on that guy. And then behavior management. I'm able to get away with things on little ones, 2 and 3 year olds that I never would have done before. I mean, we're talking extraction of, like, this patient, their ortho wanted all 4 lower incisors out. Behavior management kiddo, I gave 1 intraosseous injection there, half a carp of 2% septo with I used 1 to 100,000 epinephrine there. And that patient was profoundly numb. All 4 teeth, 1, 2, 3, 4 out of 1 injection. That was it.
Whereas before, you'd be giving like all these infiltrations all around there.
Yeah, that would have been, how many, that for me, that would have been probably 3 or 4, right? Lingual of each tooth and then in the vestibule. Yeah. And anything we can make our parents happy about, that's always good for our practices.
All right. First pearl we're going to share with you tonight is my pearl. We do this in our practice when we're onboarding new team members. We do it for our clinical and for our admin team. So I'm just showing you the clinical ones now. And we have trainers on both sides in admin and in clinical, and they are training these new team members to onboard. And so you put your task here, and instead of just being like, yes, they know it, or no, they don't know it, you collaborate with the team member and figure out, are they mastering it? Are they on the struggle bus? Are they Mayday? And so what we do is they train with one trainer for a week, and then they move to the next trainer. So this is a great tool to pass off to the next trainer that, hey, they're getting there, they're closer, or hey, they're totally good with that. You don't need to spend much time with them on that. And we do that. We have different checklists that we expect them to be proficient in 30, 60, and 90 days. So if anybody wants I mean, obviously make yours your own, but if you'd like a copy of mine, please feel free to email me. I'm happy to send it to you. Lots of people asked for it after the last one. So hopefully somebody's getting their crap together on the training side of things in their practice, which is always nice to hear.
Yeah, can I say one thing about that? If you are, doesn't matter what size practice you have, if you are, let's say, a startup and you only have 1 or 2 employees and you don't think, you're doing all training yourself, do this now, because this will pay. I wish I just implemented this after seeing Ann put this in my practice, after 20 years, and I kick myself because, we're doing the same trainings all the time. Do it while you have 2 people, and then you just add to it over time, and it will pay dividends. The other thing here is think about when you're training, taking your iPhone out and shooting a video. So that way you always have a record of each one of these tasks going forward. If you need, if the staff needs a reminder. So I just can't thank Dr. Ann enough for this.
So just tell us how it works. Josh, tell everybody how this is going to work.
All right. So the first thing you do is when you buy one, it comes with this thing called onboarding. And the onboarding can be done with the team members, but it should be done by the doctor. Okay. I will tell you that a lot of questions, and people are better about this now, but a lot of questions that Dr. Ann and I had early on, were very basic, and we'd ask the doctor, did you do the onboardings? No, my team members did this. You are purchasing a device to deliver drugs to children, and it would be appropriate if you know all the things. There really is not much to these devices, but there's a lot of hand-holding. NuSmile doesn't just give you these things and say, good luck. There's actually a whole onboarding process. There's videos and there's training, and then it comes with you have access to these manuals. Please read them. They're not that long, and it will go through many things we're going to go through tonight, but they're available online as a PDF. Read the manual. Okay. Early on when these devices hit the market in the US, I know there were some comments from pediatric dentists. Well, I don't need a machine to give intraosseous anesthesia. I can just put a needle in intraosseously and deliver. Yes, you could. The problem is it is speed of injection. So if you were to try to deliver the appropriate amount of local anesthetic manually intraosseously, there's no way your hand is soft enough to deliver, one, a comfortable rate of delivery, and number 2, slow enough and under enough pressure where you're not spreading the local anesthetic out in a larger field that you need. There's really a fine line here. If you want that local anesthetic to stay within a small boundary of teeth, so you want some perfusion but not too much. So with an electronically controlled device, it's going to give that local anesthetic at the correct rate and pressure every single time. One important thing to note is these are the only FDA devices in the US for delivery of intraosseous local anesthesia. There's other devices out there that are, digital delivery. They are not designed for intraosseous. These units are reading pressure hundreds and hundreds of times a minute, and they will not let you get in trouble. So if you're worried about delivering your local and herniating a follicle, or what happens if, because it's a pump and you don't feel the resistance of your hand, the unit will shut, doesn't matter, SOAN or SleeperOne, it will shut itself off. It will not let you give at too much of too high of a pressure, too fast of a speed. So diffusion, and this is an important concept. I added a photo here so we can see what the cancellous bone looks like, okay? Now this is a permanent dentition, of course, right? And so when we are delivering this local, the general rules of thumb, we can go to the next slide there with the numbers, but the general rule of thumb here is if you are truly into the cancellous bone, and not just into the osseous plate right around the teeth, but if you're in, truly giving an intraosseous injection on the upper teeth, we expect, an equal amount of teeth numb distally and mesially. So in general, we talk about 2 teeth anterior and 2 teeth mesial, 2 teeth distal, right? Again, that's, primary mixed dentition. For permanent dentition, just as a side note, it may be less than that because that needle is not really going down into the deeper areas of cancellous bone. But there is a non-bias of flow on the upper arch. On the lower arch, we can guarantee you're going to have one. If you're giving a true intraosseous injection, primary mixed dentition, you're going to be able to get 1 tooth distal, profoundly numb, and a number of teeth mesial. Usually it's 2. Sometimes you can get away with more. That's going to be dependent on the volume. But I think 1 distal and 2 mesial is a safe estimate of the number of teeth that you can anesthetize. Okay. Again, if this is a teen, you may be getting 1 mesial and 1 distal on either arch. We like to mention that because sometimes people say, well, I had a 17-year-old and I only did profoundly numb 2 teeth. Guess what? That 9mm needle is not going super deep. You may just be in the interseptal bone. You may only get 2 teeth numb on either arch. Primary dentition, mixed dentition, different story. Follow those rules: 2 and 2 and 1 distal and at least 2 mesial.
So we like to talk about the injections in 3 different stages. You'll hear stage 1, stage 2, and stage 3. And this is what we're referring to. Stage 1 is the mucosal or the periosteal injection. This is where you're holding the needle in a certain orientation, and your goal is to just get that tissue right against the periosteum numb so that you can then start stage 2 and stage 3. So stage 2 is going to be, you're going to take the needle out after stage 1. You're going to reorientate the needle. We're going to show you that. And you're going to penetrate into bone. You're not giving any anesthetic in stage 2. You're making sure that you have your bone placed properly, or your needle placed properly in the bone. And then stage 3 is stepping back on the pedal to deliver the anesthetic. So this is what the pedal looks like. It's very similar for the SOAN and for the SleeperOne. You've got an outer pedal and an inner pedal. And I like to think of the inner pedal small, like a papilla. So you're stepping on that middle pedal when you're giving stage 1, when you're giving that mucosal or that papillary injection right there for the periosteum. And there's a D that will be on every single Effitech needle that you come into contact with. And that D needs to be facing away from the patient. So it needs to be facing buccally or lingually. Your eyes need to be able to see that D as you're giving the injection, because that is making sure that the orientation of that business end of the needle, like Josh said, this needle is like a scalpel blade, and we want that needle to lean into the tissue and just almost like melt into it. And if you have that turned wrong, that is when it's going to hurt the patient.
And can you go back one quick second? Because one thing that came up for me today is when your teams are setting up your devices, make sure they don't over tighten that needle. Okay, the thread pitch on the container, and the container is where the carpula of local anesthetic is held in, it's a very long end there to twist onto. You don't want them torquing things down. I had one today. My team member torqued it down, and you're going to often want to rotate that needle around. So ask your team members, really, it only needs to be on there, kind of half, 3/4. They don't need to twist it all the way down, because you're going to want to sometimes reorientate the D on your needle.
Right. And I like it how it is set up right here. I like to have the D in line with all my controls. It doesn't matter if you're using the SleeperOne, because the light, like Josh said, goes all the way around the device. The light is talking to you. It's going to communicate to you. We're going to tell you what it's meaning here in a minute. But on the SOAN, there's only lights on one plane of the device. So I want to be able to see all those lights and what the device is telling me. At the same time, I'm looking at that D.
So, Ann, question for you. If you're giving an injection, let's say for KL, do you always have the D facing the lights, or do you have it turned opposite so the D is on the outside and the lights are facing you?
I always have it facing, because I'm usually standing up for K and L because I have a counter right behind me.
Got it. So
I can't be at 12 o'clock or 1 o'clock or 2. I usually have to stand.
Gotcha.
But yeah, I just always have them just do it in this orientation. I understand what you're saying, though. Okay, so step one, Josh.
Okay, super, super important point. And the reason why I make this is because I worked with a doc last week that was having pain almost every single time. Well, they weren't in pain. Their patient was in pain every time that they would give an injection. When we talk about papillary triangle, it is, if you look at the papilla there and you make a triangle, the base is just slightly under, if you look at the free gingival margin to the tip of the papilla, that is your papillary triangle, okay? So if you were to split that in half, that is not where I want the needle to enter. So our goal is to profoundly anesthetize that small amount of soft tissue and the periosteum underneath it. Your periosteum is highly, highly innervated. What else in this area is highly innervated is your PDL. So we want our needle to stay away from the periosteum and away from the PDL when we give this initial injection. So, and the important point that Dr. Ann just made is the needles are so sharp. I don't want you to think about pushing. I want you to think about literally, you have the D facing out, and it is so sharp. If I had one here, I'd put one in my hand. You do not feel it. You just need to lay the needle on the tissue. Just think about putting a little pressure, and it will slide right in. But what I want you to concentrate, I think we need to go one. Does it have the next drawing here? Yeah. So I don't want you to enter that needle right the middle of that papillary triangle, because the doctor that sent me videos last week, she entered right in the middle and she would advance, and she was likely poking the PDL of tooth number T. And that's why their patient was grunting literally every single time. It was either from the pressure of the local anesthetic near the PDL or actually the needle touching the PDL. So you want to go, like in this case, I would say, about a millimeter mesial to the middle of that papilla. And when you do that and you slightly just lay the needle in, then your needle will advance to just about the center of that papillary triangle. The other thing you have to remember is when you're giving that local, when the D is facing out, that lumen is facing the tissue or facing the bone, and you want to be right pretty much in the middle of that papillary triangle when you're delivering. But if you start at the middle and then advance, you're going to be way too close to the adjacent tooth. It's got to deliver right in the middle itself. So not the needle, but the liquid. One way to think about it is that local anesthetic is going to move ahead of or in front of that needle. So don't go in the middle because it's going to be too far laterally to one side.
And if you can get this part done, people think like getting in the bone is the hardest part. If you can master this first stage, you're golden for the rest of what you need to use with these devices. So this is Dr. Megan in my practice. The D's facing out. Her foot's on the pedal before she even goes into the tissue. And you can see the needles flex. They don't break. She's flexing that needle and she's in there. That kid does not care.
One point here is Dr. Megan would typically normally fulcrum on the tooth itself and not on the soft tissue. She did that just for the video, because if you do it perfectly, people can't. The only person that can see there is the doctor. So when you give that initial stage, our suggestion is to fulcrum one of your fingers off the tooth, because if your patient does move, you want to have your hand move with them. That's just for the video. So get a fulcrum on the tooth, then give your first stage.
All right, here are some more first stages. This is actually me. Oh, and turn the D out. Good job. And I like to just show that those needles, they flex, and that's great. Here's another one over here. This is Dr. Nash in our practice. You almost think you're not even in the tissue, though. That's the thing.
That's
You just have to go so superficial. Sometimes I'm looking at it like, oh my God, am I in there? Or is like anesthetic dripping everywhere?
One quick point about the first video on the left. Do you see how Dr. Ann is in more of a vertical position, where Dr. Nash is a little bit more horizontal? Now, sometimes you can't ideally have your patient in the perfect position all the time. I do want you to be a little careful if you are going to give your first stage in more of a vertical direction like that. And the reason being is if your patient moves a little bit or you're not 100% steady and know where to inject, it's a little easier to touch the bone vertical. So if you look at a lot of the examples, we initially teach more of a horizontal approach because then you're going slightly above the bone versus vertical if it is easier to overturn and touch the periosteum there. So ideally, you're going to be more in a position there like on the right, but sometimes you got to do what you got to do. And if you can't get in horizontal, you got to give an injection like that on the right, but just be a little bit more cautious on your depth.
So this is stage 3, actually. Remember, stage 2 is we're going to get that needle into the bone. And then stage 3 will be stepping on the outside rim of this petal right here. And these are some examples of what stage 2 and stage 3 look like. I put the x-ray up here so you can see, like, one of the most important things is you got to have some bone. So if you've got some abscess, giant problem going on, or you've got some over-retain this and that, that's not the time you're using the device as intraosseous. You're going to use the device and infiltrate the tissue and deal with whatever you got to deal with. Or if it's an abscess tooth, you got to find some good bone that you can harvest to find a site to inject into. But here are, I don't know why this one's not going. Well, we'll watch this one first. So going in, I like to be able to see part of the needle at all times. I'm constantly like either rotating it in to see if it can go any further, and then I'm giving it a tug back to see to make sure it's in there. Now, if you tug back on that too hard, it's coming all the way out. It is a very gentle touch to see if it's in there. And then we start depositing, and then I'll go over to this one. So see there, Dr. Nash, he's twisting it. The closer you can choke up on the device, and the more stability and tactile sense I feel like you have. I'm just showing the blinking lights there because they start blinking too much, and that's telling you you've got too much pressure going on. Here's another kiddo. Again, we don't have any real bone between those two stainless steel crowns right there, but we got a nice slice of bone right there between that permanent premolar and that first molar.
If you have primary teeth that are close to exfoliation there, one of the things we need to remember, like Ann said, is, if you don't have roots on your primary teeth, you don't have nerves sitting in the cancellous bone, right? So one important key point to remember is you can use these devices still for just soft tissue, right? There's a setting you can change, like on the SOAN, you can change it from beef, bone, blue to the purple setting and just give in the soft tissue. So if you're struggling, and some people say, well, their patients are still feeling it, there's no nerve left in those teeth, right? So you want to profoundly give local in the soft tissue and really worry about soft tissue blanching and not in the bone itself.
Right. And also in this, there is some root left on that tooth. So definitely This is not just coronal remnants that you're infiltrating around. And also they're going to do some work on that adult molar back there at the same time.
And if you were only going to numb for that over-retained primary, would you still give IO there, or would you just give more of a soft tissue? Yeah.
I would. Yeah. It's going to be a slam dunk. Yeah, I definitely would. All right. Pearl number 2, also my pearl. This is merch that we give out. And this is Jeanette McLean is the one who turned me on to these cute little picture frames. They're magnets. And this is what we give out at new patient visits, and parents love it. So we have the little camera set up, the printer set up, the dental assistant that is seeing the patient handles all of this, and they give it to the parent. And it's just a cute little, we can all give out the lip balm and the toothbrush, but this is just one more added nice little soft touch that you can provide for your new families. and that they probably won't get somewhere else, right? If they choose to leave you for money or insurance or whatever, they're probably not getting this at the place down the street. So I did end up adding a QR code for the website that I order them off of, because so many people have asked me where I get them. And there are a lot of places that don't do this. I was surprised, like Vista Prints doesn't have it, but this custom magnet company does these. So again, there's the QR code for that. So let's talk about these blinking lights. If we're talking about the SleeperOne, and let me just straight up tell you this. If you're on the fence of which one to get, I used to think you would want the portable unit if you're going to move the unit around, and I still believe that, so that you can move it room to room. But if you have a lot of hands on these devices, a lot of assistants or sterilization techs or whatever, like tearing them down or cleaning them or putting them together, there are so many more, or there are so many more buttons on that SOAN that they can push and mess up the settings on. There are no buttons on this. This is like Intraosseous for dummies. I love this device because I literally go in the room and put my foot on the pedal and go. There's no thinking, oh my gosh, is the setting wrong? Is it going to stop at half a carpule? Is it going to retract? Like, what's going to happen here? So I think this is a much simpler device. So blue is, if the blue light is flashing, there's two settings for this. If the blue light's flashing, you're using it for an intraosseous injection. You can also put it in the pink setting, which you would use for, like, if you're going to give a PDL or an infiltration or something like that. And then you've got orange, is for the infiltration and for the block, which I don't ever really have it on orange unless I'm doing some coronal remnants, because no one's getting a block. All right, and the SOAN, again, we've got lights that are telling us a story. If the lights are blinking blue tells you that you're in the intraosseous mode. If they're pink, or it sort of looks like a purpley color, this is for an infiltration. And those are the only colors. There is no orange on the SOAN. It's just those two colors, blue for bone and pink/purple for infiltrations. Then the lights blink and talk to you in that effect as well. So one light blinking, if it's not blinking at all, your foot's not on the pedal, or the unit's off, or something's going on. So you've got to have the device blinking for anesthetic to be getting delivered. If you've got one light blinking, you're a go for launch. Go ahead and start delivering. If you've got two lights blinking, you're still good. That's just telling you that some pressure is building up as the anesthetic is leaving the device and trying to perfuse into the bone, that it's reaching some pressure. And that's not normally anything you're doing. That could just be like the size of the lumens in the bone. If you've got three, you've got to start paying attention, because now you are going to be getting some back pressure, and the device usually will slow itself down at this point and stop delivering it at that rate so that it can accommodate for this excessive pressure. Once you get to four lights blinking, you've reached too much pressure. If you don't physically do something to adjust this pressure, the device is going to do it for you, like Josh said, so you don't get into trouble and cause, some sort of I guess it wouldn't be an embolism, but it would hurt probably if you kept going, pumping it in there. And this is a mayday. So we're going to talk about what to do when this happens. But if you don't adjust, the device is going to do it. It's going to shut itself off, and it's going to retract the carpule. So what causes the device to recognize the pressure? Maybe you've got the needle pressed up too far on the bone, right? Like if you've got the straw in a McDonald's cup pushed too far deep into the cup and you try to suck out of it, you can't get any liquid out of it. That's the same thing in reverse. If you've got that needle butted up to the bone too tight, anesthetic can't come out of that. So that can be the first problem. The second thing could be that while you were in there twisting it and trying to get it through the bone, you picked up a piece of bony spicule in there, and now it's stuck and it's clogging the lumen of your needle. You could have a bent needle that, now you've got a bend in it, nothing will go through it. And also it could be that the bone just isn't porous enough to accept the rate of the anesthetic that you are trying to deliver. So these are about the most common things. And the things that we recommend to try to eliminate it yourself is just give the device a second. It's probably going to figure it out and adjust the rate at which it's going to deliver. The second thing you can do is you can back the needle off of the bone just a little bit to see if the anesthetic will flow. You can remove the needle and reposition it if you feel that's the necessary route to go. And then, you can always just put a new needle on. This is the order that I would tell you to go in to try to troubleshoot it. What we don't want to see you do is to panic and take your foot off the pedal. Every time you take your foot off that pedal and you put your foot back on the pedal, the device has to ramp back up. It starts really, really slow, and until it has the confidence that it's delivering anesthetic at the right rate, it's not going to increase anymore. So every time your foot goes on and off that pedal, you're actually slowing down the process of delivering anesthetic to the patient. Don't start and stop the device, like I said. All right, Josh, talk to us about why we're picking certain anesthetics, because you've talked before about how you're using septo and what concentration.
All right. So first of all, topical. Many or most of you will use topical at first because you're worried about it. And I will tell you that I don't even really know where the topical is in my office anymore. It's somewhere, but rarely, ever do we use it. I think the only time we'll reach for it, it's more, I think, just to make ourselves feel better. If you have that patient where you're mostly giving a local soft tissue and you're using this more for local infiltration and they've got infection, super loose teeth where you're just using a device, and this is great just to give for just local infiltration, I may use topical. That is once in a blue moon. I promise you can give an absolutely painless injection without topical every single time. You don't need it. So topical, I had a restoration done last year for the first time in a long time. The worst part was the topical because it got back in my throat and I hated it. You don't need it. Next slide. Put it away. All right. So beautiful. Next. Thank you. Okay. Of course, there's two major local anesthetics that we use in pediatric dentistry, articaine and lidocaine. Lidocaine you can use lidocaine in these devices. If you really feel like it's something where you feel more comfortable with lidocaine, fine. But I will tell you that 95% of the people that are using the devices are just using articaine or septicaine. A couple reasons why. The big thing there is that theophylline group, so it is more soluble. Thank you so much. And then also these are metabolized. Septicaine is metabolized in the blood and not the liver, so there's a larger safety profile there. Okay. And you see there that, 95% in the blood, that's for the amounts of local that we use for children, although we're staying way under our max dosages. I want a local anesthetic that is metabolized in the blood and not all the way getting to the liver. Okay. And then if you go to the next slide, the important thing here is speed. Okay. That 1 milliliter per minute is the ideal time to deliver local anesthetic, both for comfort for the patient and making sure that we have perfusion rates that are appropriate. Now, what is the actual perfusion rate for most of us patients with a standard syringe? It's how long it takes to push the plunger down. These devices are not taking any longer than you should be giving your local anesthetic in the first place. Okay, important. We can just click on this so we can see everything. There are two different formulations of septicaine and articaine that it's in the US. If you look at literature, if you see 1 to 50, they actually have that in Europe. But these are the two anesthetic concentration of septicaine that I keep in my practice. A vast majority of the time, we're using 4% articaine with 1 to 200,000 epinephrine. The reason for that is I want to have a little bit more perfusion of my local anesthetic. And so if we're using more epinephrine, those vessels will clamp down easier, and you won't have the spread of local over a certain amount of teeth. Okay. If you are really worried about asymptomatic teeth and you're not trying to get as much local next to one tooth, I would use 1 to 200,000. I think it is by far safety profile used to 1 to 200,000. For teenagers, please use the 1 to 200,000 because we know that we're delivering most of the time just the interseptal bone, and there's much less of a chance of having any issues with sloughing. Very few and far between, at least in my hands, I'm using 1 to 100,000. If it is a hot tooth and I really want to do everything possible to to get that tooth anesthetized, I'm using the 1 to 200,000 or 1 to 100,000. Thank you.
So why, we hear this all the time, why is septo only FDA approved for kids age 4 and up? Well, that's just really not true. It was that the clinical study only enrolled patients age 4 to 79. People weren't lining up with their 2 and 3-year-olds to volunteer for a study. And I don't know where the 80-year-old people were during this study either. But that is, kind of a big roadblock or hurdle that we face is it safe? It's not that it's not safe. It's just that those patients weren't included in this study that gets quoted over and over again. And there's lots of other studies that have been done in other countries that support that, it is very safe to use on patients below age 4. So safety and efficacy of Articade during pulpotomies, age 3 to 4. So there's one, that's a study in 2020 in the International Journal of Pediatric Dentistry. So that's at least 1 year younger for you, showing that it's safe. Subtecaine is eliminated from the body faster than any other local anesthetic. So if you really want to talk about what is the safest for our patient population, it really is septo over lido. Lido was first to market, and the reps, that's what they sold all of us, and it just became like the Kleenex of tissue papers. 90% of septo is metabolized in the tissue and not the blood, which means it doesn't go through the liver. So that's another good reason to, keep it in the bodies of these little people whose metabolism is a lot faster than us geezers on here. So another thing that we hear that we want to knock out tonight is, why does it go so slow? It's really just feeling that way. Once you realize how fast your entire op appointment goes, you're going to be like, okay, I will suffer through this slow injection if I know that on the other side of this, I can get my opt in faster and get my rim turned over and not be running oxygen and nitrous through my tanks any longer than I need to while I'm waiting for anesthetic to set in. Josh already talked about this, but if you're delivering it yourself, you're really supposed to deliver, if you're delivering it traditionally, a mil per minute. So you really should be taking 2 minutes to deliver an injection anyways, which I don't think any of us do. All right, so here's going to be an example of a treatment that Dr. Megan is doing. Topical, stage 1. Shifting to stage 2. She's watching those lights to make sure they don't go up. All right, it's time to party. So speaking of this, DryVax, ISO lights, whatever you're using, you can actually put those in ahead of time before you give the injection if you want. Then they don't taste any of the nasty anesthetic that may dribble out. So she's doing a restoration here on this lateral. Polishing it up. Two teeth are out. And that was a 7.5 minute start to finish appointment. So you want to talk about ROI, you want to talk about compassionate to your patient, you want to talk about the parent that's standing at that window watching their kid. Sure is a lot more compassionate for that parent to watch 7.5 minutes go by than 30 minutes go by with their kid in the chair. And the other really cool thing about these devices, I really can't explain this magic, but very little bleeding in the sockets. Like, obviously, if this kid is screaming his head off, that's going to increase pressure and there may be more bleeding, but most of the time, very little to no bleeding of the sockets when you're done with an op. Here was one that Dr. Nash did in our practice, and in his defense, this was his first time using a SOAN to take out an adult permanent tooth. So he chose to, just for his confidence and comfort level, he numbed on both sides of the tooth because he just was like, I don't know yet. I'm not sure I trust the process. So he did choose to go mesial and distally to that premolar. And I'm talking set the device down, pick up an elevator, all in one motion. So tooth is out. That was less than 7 minutes. That kid can go back to school or cut the rest of the day or whatever, but he's out of your dental chair. This is about one of the most compassionate things you can do for the little kids who just, we don't have behavior management tools in our toolbox sometimes when they're just, too young to understand what's going on. So here's a, sad little kid. Whereas before you'd have to numb this kid, then set him up. We don't make them lay there the whole time while the anesthetic is taking effect. You would numb them with a traditional syringe, let them sit up, cry in their mom's lap or with the assistant for 5 minutes or whatever, then lean them back in the chair for, the main course of doing the work or taking the teeth out. So literally talking to the parent about what needed to happen probably took longer than what you just saw right there with that kiddo. That was 2 minutes, start to finish. That's super compassionate for a little kid like that and for a parent who's, suffering watching their kid go through that.
Oh, one of my favorites, palatal access. So I was a little worried about, giving any injection palatally because we all know from dental school, giving greater palatine is probably one of the most painful things out there. But as Ann mentioned, we need to find decent bone. And if you have we know most of the time if we're going to see draining fistula, it's usually on the facial or buccal aspect of the teeth. There is no difference to give, your IO injection on the buccal or to give it on the palatal. Just do it. Thanks. I always want to mention Dr. Eric Hans for the ones who pushed me to do this. They say, don't be a baby. It does not hurt more. It's not going to be more difficult. Sometimes I think it's actually easier to get through that palatal bone there. You can go a little bit closer to the teeth. The bone is thin, pop right through, and it will not be an issue. So just something to remember. And it's easier to see as well. So if you're right-handed and it's on, let's say you're anesthetizing I and J, it's a whole lot easier to see the palatal surface of the soft tissue and teeth than it is on the buccal. If you don't feel comfortable with that, just make sure you can turn your patient's head way over to the right if you're right-handed and access the buccal aspect. And here you go. Even easier access here on the lower left if you're right-handed, right? Stage 1, stage 2, stage 3, it's all the same. And you've got great access of bone here. And, if you look at like a CT, the volume of cancellous bone is greater there on the lingual surface here. You've got a bigger vessel to inject into, not the actual cancellous bone itself. And this is a great option for giving local on the lingual approach. Another angulation here on the palate. Now, as I mentioned earlier, if you're new to this, be a little careful giving that stage 1 vertically because you don't have as much control vertically as you do horizontally. So my opinion is when you first start, you may not want to go an approach like this. If you can tilt the patient's head over, is to try to give that horizontal approach for the first stage. But if you can't, you can do it this way. Just be careful on your angulation and you're not tapping that periosteum in this first stage. Hypo teeth. If these devices could do nothing else besides anesthetize primary anterior teeth and hypoplastic sixes, I would take it. We know that even without looking at a study, that hypoplastic teeth, especially hypoplastic molars, can be the scourge of pediatric dentists. Both they're difficult to restore and getting these teeth numb. And I would probably say was about 2/3 successful giving a block to hypoplastic teeth. So I'd have to give a block and an infiltration and everything else to try to get profound local. Well, it turns out, we can go to the next slide there. It turns out there's a reason for this.
Can I show this video real quick, Josh?
Yeah, please.
I think this is just going to show, this is a patient in our practice with a very hypoplastic tooth. I'm trying to show a lot of videos because that is one thing that we get asked a lot. Hey, can you show me more like of you doing it?
And again, the fulcrum here is not on the tooth, it's on the face. That's just for no, I lied. We're good. We would fulcrum off the tooth. Really try to get a fulcrum off the teeth. You're going to have a much easier time getting that needle through the bone. All right. So, if you look at effectiveness of intraosseous anesthesia for hypoplastic teeth, I mean, this study, 43 out of 46 patients were able to get profound local anesthetic with when they had a hypoplastic tooth. I mean, in my hands, that's worthwhile having devices just for that. Well, it turns out there's a reason for this, and I didn't know this until Dr. Patrick Reck, my dear friend and amazing clinician and educator, we can go to the next slide, brought this study to my attention, is that these hypoplastic, hypomineralized teeth actually, from a histological standpoint, are always in this state of inflammation. And that's why we not only have more difficulty getting these teeth numb. When we do get some local anesthetic effect, the local anesthetic may not last as long, or you may get just slightly into the enamel, and that patient is really having an issue with local anesthetic. These teeth do not like to be anesthetized. And I promise you, this will make your life a whole lot easier. I treat a ton of hypoplastic teeth in my practice, and I can't tell you the last time I could not get profound local anesthetic on a hypoplastic tooth.
All right, third pearl.
So pearl number 3 is not really a pearl. It's more of a gift, I should say, to all of you. So if you take a scan there, that is a QR code to a directory. These are all of my patient handouts in my practice. So there's probably, 20 or 30 of them there. We add things all the time, like that over-retained teeth. What we do in my office for a long time, I was having, when there was over-retained teeth, we'd bring the patient in, and 2/3 of the time we do exams, say, oh, you're fine. Call us later if these things bug you. So what we do now, like specifically with over-retained teeth, if the patient's not in pain, we have parents, we send this to them. They send a photo if necessary, and then it gives them all the instructions when to come back. So you have my permission to take my name and logo off any of these handouts and make them your own. We have ones for primary gingivitis, all my GA handouts, pre and post-op, lots of stuff in there. The one thing I ask, if you have any good handouts in your practice that you would like to share, I would appreciate you sending them to me, and I'll make it worth your while sending you stuff. But I would appreciate sending it to me. But this is all yours, carte blanche, and there you go. That may be worth being on there tonight.
So what is the difference in drive and cruise? It's exactly what it says. It's just like you would find in a car. So in drive mode, your foot is on the pedal and it's pushing down, just like think about your handpiece and your rheostat. Your foot's on the pedal, that is drive mode. Cruise mode is just like in your car. You can take your foot off the pedal and your car is still moving and still running. Same thing with these devices. You can put your foot on that foot pedal, tap it, take your foot off, the device will keep running. The issue with cruise mode is if you take the needle out when you're done and you recap it and you forget it's in cruise mode and your assistant goes to clean it up afterwards, it's full of all the anesthetic that you didn't use because it just keeps running. It doesn't know that you have stopped. So if you are going to use cruise mode, you want to get in the habit of tapping your foot before you pull that needle out of the bone, or you'll have anesthetic everywhere. Just a pro tip there. But I like to use, I don't really care. They get touched and messed up all the time. So when I go into one of the 4 treatment rooms, I never know what setting it's probably in. I just go with it. But I would prefer cruise mode because I can take my foot off the pedal. I can like be holding the device in the mouth, and I can, scroll over and look at something on the computer or I'm not like stuck with my foot on that pedal, I guess is what I'm saying.
And one of the things I've actually come to really like that time when I'm giving local intraosseously, because it gives me a few minutes where I'm not, if I'm giving a manual injection, I'm having, look and concentrate the whole time. Not that I'm not concentrating doing this, but if the machine's doing the work for you, that's, a couple minutes where I'm, talking. And after time, many of us have seen our patients and parents for a very long time. I get to actually talk to the parent and, talk to the child. And we're talking about, what Santa's going to bring them, or just checking in with parents. So it's really a few minutes that I come to love, and be able to talk to parents. And I'm just sitting here giving local and talking to parents. I mean, we're paying attention, but it's a nice time that you can, connect with your patients. All right. So many of us, when we get new toys, it's like having a new car. You want to drive around and tell all your friends all about it. And I alluded to this earlier. Sometimes parents don't want to know that you have, something brand new, because they may think it's just brand new to the States and you're, trying it on their kids. So I think how we describe this to parents is important. So when you get this, you may, not want to explain, oh, it's brand new. You can explain brand new to practice, but I would explain that, this is used by thousands of pediatric dentists. I think last count, Ann, there was 2,000 or more of these sold in the US, and I believe there's 8,000 pediatric dentists. So you can describe this, and this has really become the new standard of care, numbing children. And use the term compassionate. I love that term. This is the most compassionate way we can deliver local anesthetic. I love that term digital pump, because then parents really understand what this is. And, all those handouts are a great way. Now, NuSmile has these handouts available for purchase, or you can make one yourself. These handouts were not just something that their marketing team came up with. They polled a bunch of us, and everybody wrote this together. One practice management pearl here is this is also a great, because parents are going to love seeing this. They love that their childs are not having pain and not having a numb lip or tongue, is if you have like an internal marketing program in your practice. I don't always like to, say, hey, do you want to refer us patients? But that may be a time when you clip this to one of these devices, or one of these devices. Don't give out a device. You give out a device, it gets expensive. One of the handouts. So if you have an internal marketing program, clip it to this handout and give it to parents. And you can, they can take it and they're sitting there reading. I've heard other people say this is a magic wand, or it's going to take the temperature. Sometimes I'll, as long as we're not using isolate, I'll tell a child to listen. If they hear beeping, their tooth is falling asleep. It's a good way of just doing a distraction. And you may want to make, something for your wall. When I went and visited Dr. Ann's practice, I love that her handout here, and she's going to show it here in a minute. So you may want to take a screen capture here and make one yourself. It's quick to make, but they have these are all on the walls, correct? For parents to see?
Yes, yeah. Parents don't come in our treatment rooms to have a window that they can watch it go down. All right, so let's touch on some things that we get asked, and one of them is, why is the patient having discomfort? We got to remember it's a shorter duration of anesthetic. So sometimes, we're used to our patients leaving the office before the anesthetic starts to wear off, where it is sore from where you did a pulpotomy, or it is sore from where you just, took 2 infected teeth out. So they are feeling the treatment discomfort itself sooner, or the shorter duration of the numbness. So don't get in your head about it that you did something wrong. It's just, this is maybe like new territory for you, because the anesthetic, is shorter.
And I skipped over, I didn't mention that when we talked about anesthetics. The 1 to 200,000 will wear off 30 to 45 minutes. The 1 to 100,000 is 45 to an hour. So if you're, treating one hypoplastic molar and doing a big complex buildup, that may be a time when you want to have a little bit longer duration and use the 1 to 100,000. But don't forget, if you're, let's say you're approaching that 30, 40 minutes and you're worried about your patient maybe starting to feel something, you can just go ahead and back up and give them a couple more drops right in the bone. They're not going to feel it, and just hold them over.
Mm-hmm. The other reason your patient could be having discomfort is this is new to you. You're learning. So you may have to go in and out a couple times because you're not confident you're in the bone. Or, I mean, there are times where Josh and I are going back in or out, or the needle's dull, or and that is more sore. The more times you go in and out of that tissue, the more local trauma you're creating. And that can be what's sore for patients. Over delivery. Sometimes if we get too much anesthetic on that stage 1, you can get this ischemic effect. Now, I'll tell you, I've circled back with patients who have had this, but it wasn't uncomfortable. Like, I think probably more patients leave with some little torn up tissue, and we just don't ever hear about it or see it. I think it's the rare case where it's like really sore, but you can get this ischemic look sometimes. But again, that right there has got to hurt less than what it feels like after you've been given a block, and how your muscle and everything is just sore in the back of your mouth after a block, I have to imagine. Another reason it sore is you're in the PDL. Like Josh said, dude, that does not feel good. Do not be injecting into the PDL with a bunch of pressure, because that is definitely going to make your patient not happy.
All right. Oh, Anne's heard this slide like 10,000 times. She's probably going to roll her eyes.
I love this.
It's one of my
slide.
favorite things to talk about. Okay. This is the mantra that I say in my head literally every time that I give an injection, okay? And the reason being is we don't want to, let's say when we first get these devices, even till today, I don't want to be all excited and I pick up my SOAN and I go to give stage 1, my positioning's perfect, everything's great, and I realize the darn thing is off. So, number 1, turn it on. The default is standby mode for 10 minutes and then it shuts itself off. For 10 minutes on a full charge, you can give 30 full carps. You can change the power settings here if you really want. I don't see there's ever need to do this, but you can do it if you want. So pretty much most ops, start of the op, it's going to need to get turned on. Either your team member or you pick it up, look at it. And again, this is for the SOAN, not the SleeperOne. Make sure it's on before you take it to the mouth. Then number 2, what is our plan? So I'm going to look at my radiograph. We're going to look at our radiograph just like you would for any restoration every single time. We're going to pick our injection site, make sure the local anesthetic is correct, figure out what we're doing with suction. One quick tip about suction, what my team members do is they will listen. Let's say if I don't have a isolite in, when I'm giving that stage 1, they know when I come off the pedal, that's when they're going to bring the suction. They're going to flip it on to make sure that nothing dribbles out after I give that injection. I'm going to give my tell, show, do, review with the parent, make sure that I'm ready to roll. Then number 3 is pose pedal. Is the pedal in the correct location? This happens to me all the time where I go to give that stage 1 and I'm moving around my foot and I don't see it because when they cleaned the room or turned it over, the pedal was way under the chair. So before you bring the pokey part to the mouth, you want to make sure that that pedal is in the correct position for you. There's really, unless you're extremely talented, it's very hard to give stage 1 and then try to go do the little dance, 1 step, 2 step, looking for the pedal. Make sure it's in the right position. The other thing with the pedal is that you want to make sure, and I guess this goes under position, that the pedal is a wireless signal to the unit itself. With the SOAN, what can happen is you've got a chair that is all metal and plastic and foam and everything else is built in that chair. And you may not get a wireless signal from that pedal way deep underneath the chair to the actual unit. So what I do every single time is before I go into the mouth, I will step on the pedal and just make sure that they're talking to each other. And I make sure the patient position is correct, doctor position is correct, everybody's in the right place, and then I go. So power, plan, pedal, and position.
Pearl number 4, my pearl. Found these on Amazon. This is the QR code to it. This is how we house our cartridges, our needles, and our carpules. And they're literally right there on the counter because if I bend a needle, break a needle, need a new needle, it's dulled down, whatever, I want to be able to snag it right there on the counter, not go digging in a drawer for them.
And Ann makes a good point there. I would rather, if you can't get in bone, don't sit there and struggle with that. These needles are so sharp. The tips bend very easily. If you can't get through and you're sitting there twisting for a little bit, just take it off and do it again. Grab a new needle.
All right. Tips to make the switch easier. It's saving you. This is you. How's it saving you money?
I don't know how it's me. You talk. I think it's
saving you money. Like so much. I mean, don't get hung up on the price tag of it. Think of how you are saving time and money in your practice. And it's going to make you money. Especially if nobody around you has it. Like everybody where I live has it now. So it's not something that I'm using to separate myself out in the marketplace. But if nobody around you has it yet, it is a really nice marketing tool. I've spent, they're like, let's just call it $3,000 for these things. I have thrown $3,000 away in a month on things, pissed it away on things that are way less, giving me a way less better ROI than what this does every single day. So this is the pricing. Josh, you want to talk about that?
Sure. Basically, if you buy more of them, there's a discount. Ann and I do not get... We keep on joking. We got to work this out so we get like a piece of the action selling these. We don't get paid anything for you guys buying units, but you are at the end of the year. So if you want to take your tax burden down a little bit, if you were a good boy and girl and made lots of money this year and don't want to give it all to Uncle Sam, this is a great time to have these units in your hand. The rules are, general rules for taxes is you not only do you have to order it, you have to have it in your hot little hand. They can't just be sitting in the mail. The IRS wants to see it in your office. So this is a great time of year to buy one, either SleeperOne, you get a little discount here on units. The other important thing to note is we do not know what's going to go. These units are made in France, okay? And they're serviced here in the US if something goes wrong, but they're made in France. What we don't know is tariff changes. And it's very possible if the tariffs go way up, that these are going to become more expensive. So something to think about is buying them now, because if you look at some European cars, they're expecting 20% increase over time. So spend the money now. And needles, they're on bulk and they have specials on the needles. And this is better pricing than even when I got them.
Jordan, you want to say anything about your sale, how that's working?
Yeah, I was going to say it's 10% off through the end of the year. Of course, we're closed New Year's Day, and then Christmas Eve and Christmas. So if you want to place your order, you can do so online. The code's on there, or reach out to Aaron, myself, Isabella, or just NuSmile.
I missed the code. Where was the code?
If I'm not mistaken, I think it's on the website.
Okay.
Or it gives you instructions for it.
Okay. It's a special offer, and it's good through the end of the year. But you can't call them on Christmas Day is what he's telling you. So just give over your credit card. This is what I make all my friends do. I'm like, listen, this is a game changer. This is going to help your practice and your patients and your, reputation. So just get your credit card ready. Give it to Jordan and Aaron and get you. This is a Christmas gift. You don't need more socks or 3/4 zips or whatever. Some more tools, some pro tips we can give you are just be patient and practice. The needle's not going to go in perfect every single time. The patient's going to feel something at the beginning of this. So just be very patient and be patient with yourself. Show yourself some grace while you're learning this, and then lots of practice. So this was Thursday. This was an IV case I did on Thursday. And this is the best time to practice. If you do IV sedations or you go to the hospital, take the unit with you.
And can I say, did you see that? Can you back up? Because that is a great example of, that's a very subtle nuance. Did everybody play that over for me? Did everyone see how she just barely, she's not pushing with the needle injecting. If you see the needle slightly bend, you see that? It just literally slips into tissue. That's all you have to do. That's a great example.
Thank you, Josh. Thank you for that. And then stage 2. So again, I was trying to get some footage. My dental assistant must have an iPhone 4 because this is horrible.
iPhone potato.
But, you get the idea. I love that. Okay. Please join. Josh, go hit it. Sorry.
Please join the Facebook group. The other thing is, if you are struggling with something, one of these, please don't go on like iPedo and say, "Oh, I can't." This thing's not working. 99.9% of the time, it's a user error, and Ann and I are on this mission to continue to make this the standard of care. So if you're having a problem, if you have a question, post it on our user group. You don't actually have to own one of these in order to get on the group. That's correct, Jordan, right? You don't have to, you can just get on. So yeah, this is a very helpful, nobody's going to make fun of you if you don't know what you're doing. Ask on here. And then also, there's not as much traffic on this because so many people know how to use these now, but you can also search through all the posts. And if you have a question, and you're not sure about something, search through here. I would suggest, when you get one, just read through this, look, spend an hour or two looking through, because there's been a lot of questions that people have posted on here with a lot of good answers.
Mm-hmm. Training. NuSmile is great about if you can get a big enough group together, they will come train you. They also train residency programs. They also are they're at a lot of different dental meetings and conferences. So, you can, if you're the type of person that you need to get your hands on it first before you make the purchase decision, there's plenty of opportunities for that to take place. You can reach out to Jordan or Aaron and ask what upcoming events they're going to have. And these are just some examples of that. Like I said, school settings, different dental meetings, pearls, bourbon and baby teeth, APD. Just you can. They've been at almost every dental meeting I can think of that I've been at as a participant in the last 2 years.
Residency program, same way. If you're teaching a residency program, reach out to NuSmile. Chances are we can get somebody to volunteer to give, an hour webinar to your program. I lost track of how many I did last year, or this year, I should say.
All right. So some final pointers for everyone. When you know the solutions to all your problems, then you just don't want to do them. We are telling you tonight, this is going to solve pain points for you and for your patients. So don't be the thing that is standing in your way of doing the thing that you know that you should do. And don't overthink this. Like I said at the beginning of this, you've given every injection under the sun before you even had a dental license to practice in the state that you practice in now on patients that were super trusting. So you can do this. This is just a new tool in your toolbox, and you can do it. And don't reinvent the wheel. Don't sit there and suffer in silence. Reach out to people, read the manual, watch past webinars on the website. There's enough people using these devices now that there is no reason you have to suffer in silence. There are so many people available to help.
They will fight over helping you.
You will fight.
That's usually what happens. Yeah. Oh, to make a video, 100%. So if you send a message to Ann or I that's 17 pages long about all the problems, that does us no good. Take a video. Ask your parent or patient, or your parent for permission, and have one of your assistants who doesn't have an iPhone 2.0 potato version to take a video. And I got a couple of these the last few weeks from some docs. And then, I saw exactly what they're doing. When they were doing stage 1, they were coming at too steep at an angle, and they were pointing it to the primary molar, and that was a problem. So take a video and get it to Aaron or Jordan, and they will get it out to any of us or send it directly to us. And we can help you. The learning curve should be very short for you guys because we've already made all the mistakes and been through all the pain points. So learn from our mistakes and our experience.
So just as a reminder of why this is what you want for Christmas this year, immediate action, predictable anesthetic, especially those hypoplastic molars Josh was talking about. No delay when you deliver the anesthetic, and ability to do active treatment. Way less stressful for everybody. No one's chewing up their lip or spitting gauze out. You're optimizing your appointments, doing more dentistry, cutting down on, times when mom and dads have to take their kids out of school or take off from work, and a great reputation for your practice.
This should pay for itself in a very short period of time. If it doesn't, talk to us. We'll help you. And
if this is not this Thanksgiving, this is last Thanksgiving when our son was a D2. He's now a D3. Delivered his first bridge today. But when he was a D2,
very nice.
This is at our dining room table where I'm sitting right now, and this is his younger brother, who was a junior at Clemson at the time, and he's injecting his brother and got him numb. So
you got him through that big boy. He got through his bone there.
he did. He did it right, and
Wow.
he went canine to premolar on the top. But I'm just
Wow.
saying, if you can, just have fun with it. Don't just don't be stressful about it. But if these two, jokers can do it, I'm pretty sure everybody on this call can figure it out. These are all the people that Josh was talking about that can help you, and somebody has got to be close to you. If you live close to any of these people, get in a car, get on a short flight, go visit these people, watch them use these devices in their office for a day. We've had multiple people, Josh, I'm sure you have too, that come and just spend a day in our practice, not just to learn this, but to learn, lots of other cool things as well. So everybody on this map is here to help you master these devices. Jordan, you want to talk about your courses coming up?
Yeah, so we're going to have restore courses coming up. This is for next year. We may have one more scheduled later in the year. Haven't had that finalized yet, but as of right now, these are concrete, and we're having all of these. So next one coming up, Nashville, February 21st. If you want to join, definitely check that one out if you're able to. And then Orlando, Chicago, Los Angeles, of course. We are not having Tech Day for these. If you've joined, another one of our restore courses. And do you have the Tech Day slides? So they give you those dates yet?
No,
So
I don't know those dates.
we're going to have designated days for tech. So Dr. Solomon came down to Houston, what was that, a month or two ago? And
Yeah, that's fun.
yeah, so we're going to have basically that day is everything hands-on for SOAN, SleeperOne, some lectures, some cases. We have dental chair out there, and then the intraoral scanner as well. So we're going to have a bunch of those dates for next year as well. Those are all going to be in Houston, same area and everything else. So be on the lookout for those as well. But these are going to be our restore courses. It's going to be everything hands-on, like Ann talked about, all of our products. I actually like the way you talked about today, Josh, when you're like, it's like a 1-day residency course. Just pretty much you're going to come in, you're going to learn pretty much everything that we can throw at you. So
Got it.
Check those out if you can.
Jordan, you want to take this one or me? You?
Yeah, scan the QR code, just our upcoming webinars. These are going to be for everything. We have bioceramics, we have space maintainers, zirconia crowns, bioflex, SOAN, SleeperOne. So a little bit of everything. And we're hoping to implement some newer things this coming year. So big help.
Yeah, one quick thing, that the bioactive bioceramic webinar that Patrick Ruck gives is phenomenal. I thought I knew a fair amount about bioactives and bioceramics, and that guy knows way more than I do. He is a phenomenal educator, and it's definitely a product and a new upcoming whole segment of restorative dentistry. I would highly recommend listening to that. You will learn a ton.
And also think about it when you're on break here in the next couple of weeks. If you see on this slide, it says free CE. Who in the world is giving out free CE nowadays? No one is. We're having to pay to get our opioids with CE and all this stuff. While you're at home over break, sit down one night, watch a webinar, and get some of your CE hours before the year's up and you get audited or in trouble. These are the people that you can reach out to. They're super helpful. Jordan, Erin, who you've heard us talk about quite a few times on the call tonight, she's the sales rep as well and can help troubleshoot most things like Jordan can. And Isabella is a great sales rep as well with NuSmile to help get these devices into your hands. Some additional resources. Preston, you've probably seen the DJ. He's out and about at lots of different events. Eric does sales ops, and then Nicole, she's anywhere there's a vendor booth, there's Nicole's in charge.
Anywhere in the world.
Together, exactly. And we just want to say thank you guys so much for hanging in there with us tonight. It went a little long, but I did add quite a few more videos in tonight. This will be our last one for a while. We're not sure how many we're going to produce and put out there next year. So I was trying to squeeze in some more things by the end of the year.
And there was one question there, tips for getting profound numbness for permanent molars with the SOAN. We've had some issues with longer treatments. Again, remember your working time. So if you are just treating let's say you've got a 6 that's going to take you a while, you can and that's the case, I would use the Septo 1 to 100,000. And if anything, set a timer. And if you're worried, that it's going longer, you may need to just stop. Even if you're rubber dam, just push it out of the way a little bit and give a backup anesthetic, a couple drop, quarter of a carp just to top them over, and you'll be fine.
Which is the same thing you do with a traditional syringe.
Exactly.
So you just got to be thinking, just like everybody's made it this far in life because we think critically, right? Every kid that gets in our chair has a different tooth problem, age, medical, whatever it is. And we've all been taught to think critically.
And if you need help with permanent molars and speeding up, especially for hypoplastic ones, that's one of the main things I lecture on. So let me know. I will teach you lots of things for free 99.
Is that it? Is that the only question?
I just want to thank Dr. Ann for an amazing year of doing webinars together. That was so fun.
Thank you. It's been really fun.